Cystic fibrosis is a genetic disease caused by a mutation of the CFTR gene, and it affects many different organ systems, such as the respiratory and digestive system. It is autosomal recessive, which means that a person must inherit 2 copies of the faulty gene to be affected. The location of this gene is described as 7q31.2. The number 7 indicates that it is found on chromosome 7, and the letter Q specifies that it is on the long arm. This gene codes for a protein known as cystic fibrosis transmembrane conductance regulator, or in short, CFTR. As its name suggests, it's a transmembrane protein found mostly in epithelial cells, which line many different organs, including the lungs, pancreas, intestines, liver, and even the reproductive tract. Here, the protein's main function is to regulate the movement of chloride ions across the cell membrane, which means that it allows these ions to be pumped into various secretions. Because the movement of water closely follows ions due to osmosis, this channel also regulates how much water is drawn into these secretions. In doing so, the CFTR protein ensures that many of the body's fluids, such as mucus, digestive juices, bile, and even sweat on the skin, to remain thin, hydrated, and slippery. A genetic mutation in the CFTR gene can lead to absence or malfunction of this protein. To date, nearly 2,000 different variants of this gene has been identified, with some causing milder disease while others being more severe. The most common mutation is delta F508, in which the deletion of a single amino acid, phenylalanine, at position 508 prevents the CFTR protein from folding correctly. This defect disrupts the normal transport of chloride and water, causing many of the secretions we discussed earlier to become abnormally thick, sticky, and difficult to clear. Such changes in secretion is the reason why we see a lot of different complications in different organ systems when we speak about CF. We will now examine these effects in greater detail, and by doing so, gain a better understanding of the symptoms that characterize CF, along with their diagnosis and treatment. The lungs are the most affected organs in cystic fibrosis. When CFTR function is lost, chloride and water cannot move properly into the airway secretion. This makes the mucus that lines the airways thick and sticky, blocking small passages and preventing effective mucociliary clearance. This environment also traps bacteria, leading to repetitive respiratory infections, often with Staphylococcus aureus in children and Pseudomonas aeruginosa in teenagers or adults. Both of these complications can cause excessive coughing or wheezing, which can sound kind of like this. Following infection, inflammation arises, and repeated cycles of inflammation gradually damage the airways, leading to it becoming permanently widened and scarred, a condition known as bronchiectasis. This damage leads to shortness of breath, hypoxia, and declining lung function over time, with the most severe cases leading to pulmonary hypertension and right-sided heart failure. Diagnosis of lung involvement in CF relies on several different tools. For the repeated infections, septum cultures are used to identify which bacteria are colonizing the airways, which guides our antibiotic therapy. Chest X-rays can also be used to detect bronchiectasis, mucus plugging, and other structural changes in the lungs. Management of lung complications involves several different approaches. To keep the airways clear, daily chest physiotherapy, as well as medications such as Dornase alpha, can help the mucus more thin and easier to clear out. Because thick mucus traps bacteria, infections are usually treated with antibiotics, though some are resistant to this, which can make the treatment more challenging. To ease breathing, bronchodilators can also be prescribed, helping the airways to relax. CF also affects the gastrointestinal system, particularly the pancreas and the hepatobiliary tract, since both rely on thin, free-flowing secretions in order to function properly. In the pancreas, tiny ducts normally carry digestive enzymes into the small intestine, where they break down fats, proteins, and carbohydrates so nutrients can be absorbed. In CF, however, thick secretions block these ducts, preventing enzymes from reaching the gut. Without them, food cannot be digested efficiently, leading to malabsorption, steatorrhea, bloating, poor growth, and even malnutrition. Because fats in particular are poorly absorbed, deficiencies in fat-soluble vitamins can also occur. Over time, the trapped enzymes damage the pancreas itself, causing inflammation and scarring that progresses to pancreatic insufficiency. In many patients, this damage also affects the insulin-producing cells, resulting in CF-related diabetes. The hepatobiliary system is also affected. Normally, bile produced by the liver flows through narrow ducts into the intestine, where it helps digest fats and carry away waste. In CF, these ducts can become blocked by thickened secretions, leading to biliary stasis. This increases the risk of gallstones and gallbladder inflammation, and over time can cause focal biliary cirrhosis, where scarring forms around obstructed ducts. In some cases, cirrhosis progresses to more advanced liver diseases with complications such as portal hypertension or liver failure. The intestines are also affected by abnormally thick secretions. In newborns, this often presents as meconium ileus, a condition in which the first stool is so thick and sticky that it requires surgical intervention to remove. The diagnosis of gastrointestinal involvement depends on the site affected. In the pancreas, tests such as fecal elastase or 72-hour stool fat collection are used to confirm malabsorption, while serum immunoreactive trypsinogen is used for newborn screening. For the liver and biliary tract, liver function tests often show enzyme abnormalities. An abdominal ultrasound is useful for detecting gallstones, liver enlargement, or bile duct changes. Management of the gastrointestinal issues is aimed at restoring digestive function and protecting organ health. For pancreatic insufficiency, patients are treated with pancreatic enzyme replacement therapy, along with supplementation of fat-soluble vitamins to prevent deficiencies. Nutritional support, including high-calorie diet, is also central to care. In the liver, treatment focuses on maintaining healthy bile flow. Ursodeoxylic acid is therefore sometimes prescribed to improve bile fluidity. In the sweat glands, the CFTR protein actually works in the opposite way compared with the lungs and digestive system. Instead of pushing chloride out, it normally reabsorbs chloride and sodium from sweat before it reaches the skin surface. In CF, this reabsorption doesn't happen properly, so extra salt is carried out onto the skin. This is why people with CF often have a noticeably salty taste when kissed, and why they may be more prone to dehydration or electrolyte imbalances. This is why sweat chloride tests are so useful. By collecting sweat and measuring its salt levels, physicians can confirm whether the CFTR protein is malfunctioning, making it the golden standard for diagnosis of CF. Lastly, cystic fibrosis also affects the reproductive system, though more severely in males than females. In men, more than 95% are infertile because of a condition called congenital bilateral absence of the vas deferens. During development, these ducts, which normally carry sperm out of the testes, are either blocked by thick secretions or fail to form at all. As a result, sperm cannot reach the semen, even though sperm production is normal. Up to this point, we have looked at how some of the symptoms in CF can be indirectly managed. In recent years, however, a new class of medicines called CFTR modulators has changed how CF is treated. Unlike traditional therapies, CFTR modulators act directly on the defective CFTR protein itself. These modulators come in different types. Potentiators, such as ivacaftor, help CFTR proteins at the cell surface to stay open longer, improving chloride and water flow. Correctors, such as lumacaftor and tezacaftor, assist misfolded proteins like those caused by the delta F508 mutation, allowing them to fold more correctly and reach the cell surface. The most powerful approach, however, is triple combination therapy, which is when you use two correctors together with one potentiator to increase both the amount of CFTR protein and to keep it open longer.